It's my pleasure to introduce Dr. Steven Vagiuspak. He's a professor of internal medicine and pediatrics at University of Texas, MD Anderson Cancer Center in Houston. Dr. Vagiuspak is constantly recognized as one of America's top doctors for cancer in endocrinology. His major clinical and research interests are focused on thyroid cancer, pituitary tumors, and hereditary syndromes of endocrine neoplasia. Today, Dr. Vagiuspak will talk about PPGL in children, an update of a phenomenally rare disease.
All right, well, thank you, Monica, and thank you all for being here. And let's see if I can try to keep this lively so we don't get that post-prandial slump that we are probably all experiencing right now. So I do have a financial disclosure, but it's not relevant to this presentation today. So what I'd like to do over the course of the next hour is review how children with PPGL, pheochromocytoma paragangliomas, present clinically and what you might expect if you see these children in your clinics, as well as giving you an update on the most common hereditary tumor syndromes associated with these. And each year it seems like we're adding to this list. So it's sometimes hard to keep up on all of this. I'd like to just briefly, particularly for Heidi Shea, highlight differences between adults and children who present with pheochromocytoma or paraganglioma, just to kind of show you the little bit of difference that we see there. And you'll understand why once we talk more about the genetics. And then I'd like to bring you up to date on current diagnosis and treatment of how we manage these, but also throw in more information about how we treat metastatic disease, because I think that's an evolving field as well that most of us have not seen patients with this kind of condition. So let's start with some basic terminology, because this is very confusing. It took me years to finally figure this out, right? But a pheochromocytoma is a tumor arising from the catecholamine-producing cells of the adrenal medulla. But actually, the adrenal medulla is a paraganglion. And so this is also, it could be known as an intraadrenal paraganglioma. And a paraganglioma is a tumor that arises from paraganglial cells, which are part of the autonomic nervous system. A paraganglioma, as I mentioned, arises from any paraganglion, including the adrenal, where it's called a pheochromocytoma. And this used to be called an extraadrenal pheochromocytoma. So when you read some of the older literature, you might be a little confused because they called everything pheo, but it was an extraadrenal pheo and just a pheo. But that's kind of, the main terminology that we use. And to make it easy, we just say PPGL instead of always repeating the full name of each. So that's where the PPGL comes from. So let's talk about, we'll start with the paragangliomas, because again, this is not something we as pediatric endocrinologists have a lot of exposure to. And so it is something that I always have to remind myself, particularly looking at some of the older terminology that you see listed here. So paragangliomas can be either parasitic. Remember I said they come from the autonomic nervous system. So they can be either parasympathetic or sympathetic. Parasympathetic tumors don't typically secrete catecholamines. They're silent tumors. So they present with signs or symptoms of mass effect usually. Sympathetic paragangliomas are active, hormonally active tumors that secrete catecholamine, specifically norepinephrine and its metabolite normetanephrine, and thus present more with signs and symptoms of catecholamine excess. So paraganglia are located throughout the body, from the skull base all the way down through the pelvis. And so these tumors can really arise at any of these locations. So here you see, at least for the parasympathetic tumors, they tend to be in the head and neck region and up to the upper chest. So these tumors occur all the way from the middle ear behind the tympanic membrane. Most of them are occurring up here near the carotid body, but they can also occur in the chest and the aortopulmonary window. If you look at the older literature, these are also known as glomus tumors or chemodectomas. I mentioned these are mostly silent. And again, these are the major locations for these in the head and neck and upper chest region. So usually how they'll present is just a mass. Just, oh, I've got this thing growing in my upper neck. If it's by the ear, you might have ringing in the ears or some other auditory symptoms. So that's usually how it's picked up when you present clinically. So here's some clinical pictures of what these look like. So a glomus tympanicum, a middle ear paraganglioma, is actually the only one you can see with the naked eye. So this is a patient I saw who you could see behind the TM that he had this tumor. In the middle is a carotid body paraganglioma that it presents as a firm mass in the location of the carotid body. And to the right, you can see an aortopulmonary window paraganglioma. This was a young girl that we're still not quite sure what's going on with her and why she has all of this, but this is one of several paragangliomas that she has. So again, sympathetic paragangliomas, they tend to be located more in the chest and abdomen and pelvis, and they secrete catecholamines in the majority, but not all cases. So these can be also silent tumors. I mentioned the chest, but particularly it's along the posterior, that's the posterior mediastinum. It's where that, that chain of paraganglia is, that's right next to the spine. The most common location of a paraganglioma in general is in this collection of paraganglia called the organs of Zuckerkandl that are located right here. You see right by the bifurcation of the aorta and the abdomen. Here are some examples of what these look like. So this is a thoracic paraganglioma. You see here, here's the aorta, and it's arising right next to the spine in the posterior mediastinum. And this is a classic paraganglioma at the organs of Zuckerkandl in the abdomen. So of the sympathetic tumors, which include the sympathetic paragangliomas as well as pheochromocytomas, there's different phenotypes that exist. So let's break this down a little bit more. And I'm going to start just with reminding all of us, right, catecholamine synthesis, because this is not something you think about every day. So remember that tyrosine is an amino acid that's the building block of all catecholamines. And then that's through enzymatic conversion becomes dopamine, which then gets converted to norepinephrine, and then finally epinephrine. And then these catecholamines, so these are collectively known as catecholamines. These catecholamines are then broken down by the body into their byproducts, which are known as metanephrines. Okay, so norepinephrine becomes normetanephrine, epinephrine becomes metanephrine, and further breakdown leads to VMA, which I'll just mention once because this is really not used anymore clinically, at least in our area. They still will check this for children with neuroblastoma, but at least on the endocrine side, we don't check VMA levels. And then dopamine primarily gets converted to this product called 3-methoxytyramine, which then further gets converted to HVA. So again, that's another breakdown product that is used in oncology, but not in endocrinology. So we have adrenergic tumors. So again, we have the sympathetic tumors. And then of those, we have adrenergic tumors. And adrenergic tumors are those that secrete both norepi and epi. And these are usually pheochromocytomas. They're in the adrenal. We don't see adrenergic paragangliomas. Noradrenergic tumors secrete only norepinephrine and normetanephrine. And the reason for that is because those tumors don't possess this enzyme called PNMT. So those tumors cannot convert norepi to epi. So they solely secrete norepinephrine and normetanephrine. So all paragangliomas, or almost all, are noradrenergic tumors. So the profile you'll see clinically is they have high norepi, normeta, but their epi and metas are normal, or sometimes even in the low range. And then finally, we have the rarest of the beasts, which is a dopaminergic tumor. So there can be tumors, these would be paragangliomas, that secrete purely dopamine and its metabolite 3-methoxytyramine. As you guys know, this is quite a rare disease, hence the picture of the zebra on the objective slide. So we're talking only, maybe 2 cases per million per year in children. But if you look at all hypertensive children, it represents up to 2% of those patients. When looking at all PPGLs, about 13% will present during childhood. So most of these are still diagnosed as adults, but we will see a fair proportion presenting to our clinics. In children, the average age of diagnosis is about 13 years. And importantly, children primarily have paragangliomas. They have more commonly will have paragangliomas, not pheochromocytomas. And because of the strong hereditary connection that we'll review, they have a higher frequency of bilateral tumors and multifocal tumors. In childhood, about 80% of PPGLs have a hereditary link, and that leads to the recommendation that any child, and actually this applies to any patient presenting with a PPGL, needs to have genetic counseling and testing. There's also a higher rate of malignancy in childhood PPGL, particularly paragangliomas. We'll talk a little bit more about that later. So this was a nice study from the NIH that compared adults and children with PPGL, just to kind of show us some of the differences that exist. And just to highlight, paragangliomas more commonly seen in children, multifocal disease more common, hereditary cases more common, recurrent primary tumors more common, and that lends itself to the underlying, that's because of the underlying genetics that makes them at higher risk. And again, metastatic disease we see more commonly in children, proportionately. We still see more cases in adults, but proportionately it's going to be more common in children. And then children primarily have a noradrenergic phenotype. So we don't tend to see as many adrenergic pheochromocytomas in childhood. And again, you'll see that's because of the genetics of this disease. How do children present? Well, as I mentioned, the hypertension is children with hypertension, 2% will have a PPGL. So of those with PPGL, how do they present? They mostly present with hypertension. So in 70 to 90%, usually it's sustained. And what that means is, you remember when we were in med school, we probably learned that PHEOs are associated with spells, right? And the spells are headaches, palpitations, and diaphoresis. So you get spells with adrenergic tumors. So you have to have periodic secretion of epinephrine to get that. In childhood, they're primarily noradrenergic, norepinephrine secreting tumors, and that usually presents more with sustained hypertension and not really the spells that we all learned about when we first heard of this tumor. But they can still have sweating. They can have visual problems, weight loss, nausea, vomiting, polyuria, polydipsia. These are all well-described symptoms of catecholamine excess during childhood. And importantly, they can start to decline in their school performance because, if you're kind of sitting there constantly with these high catecholamines, it's a little hard to settle down and do the work you need to do. And behavioral problems may result as well. And I've already mentioned that we don't tend to see this classic triad in children. As one would expect, hereditary tumors tend to be associated with less frequent symptoms. And that's often because, at least nowadays, we're picking these tumors up earlier through screening. And then I would think that's the reason that we see that. Again, looking at signs and symptoms about what's different between younger patients and older patients, we see the sustained hypertension much more commonly, less paroxysms, and interestingly, a lot more visual disturbance in some of these other kind of vaguer symptoms that we mentioned already. So let's dig into the genetics of PPGL. And, I remember being taught that PHEO was the rule of tens. You guys have heard that before? That it's 10% in children, 10% hereditary, 10% malignant. But the rule of tens no longer apply. It really isn't. And if you look at all PPGLs, right now, 30 to 40% of all of them are hereditary. And so we no longer use that term, the rule of tens. But this goes to show you, the earliest known diseases associated with PPGL were NF1 and von Hippel-Lindau disease, followed by MEN2. And then only more recently, the familial paraganglioma syndromes were described. And then, of course, so these were clinical diagnoses, and then as genetics, evolution in genetics, we were able to identify, the various mutations associated with these various syndromes. And then more recently, there's been this explosion of all these other genes that have been associated with these tumors. So I always think about PPGL as, getting your ABCs and 1, 2, 3s. It's a little complicated trying to keep track of all these syndromes and genes and that have lots of letters and numbers. But hopefully by the end of the talk, you'll have some more clarity about this. So a good rule of thumb is a child presenting with a pheochromocytoma is probably going to have VHL until proven otherwise. The second rule of thumb is a child presenting with a paraganglioma is almost always going to have an SDH mutation, typically SDHB. And I know the natural thought process is we think child pheo, we think MEN2 and a RET mutation, but that's actually a very, very rare presentation. Usually pheos and MEN2 occur at an older age, usually in the 3rd decade of life, and maybe some with MEN2B will present in the 2nd decade of life. So for board questions, you don't want to answer RET. That's not the most common cause of PPGL. These are some other genes that we'll briefly touch on. Specifically, I'll spend a little bit of time on the familial paraganglioma syndromes, but just keep in mind, again, a child with this disease has a hereditary condition until proven otherwise. So let's talk about the most common, von Hippel-Lindau disease. So, VHL is this multi-tumor syndrome. It is a multiple endocrine tumor syndrome, but it's also just has other tumors as well. And, these patients get benign blood vessel tumors called hemangioblastomas of their retina, of the CNS, throughout the brain, as well as the spinal cord. They can get endolymphatic sac tumors, which cause hearing loss. Moving down, we see, of course, pheochromocytoma occurs in about up to 1/3 of patients with VHL. But the other endocrine manifestation people often don't remember about VHL, they also get neuroendocrine tumors in the pancreas. So that is another clinical manifestation that we have to assess. The main things that cause a lot of grief is actually renal cell carcinoma. So these patients can get RCC, and if it metastasizes, then it becomes an incurable cancer. And they can get cystadenomas in the epididymis or the broad ligament in females. And then most recently, this is not yet fully fleshed out yet, but we've seen now several young women who get ovarian sex steroid tumors. So they have VHL and they present with androgen excess. And are found to have these very rare tumors called sex steroid tumors. So I think that we haven't yet published this, hopefully soon, but I think that will be another endocrine manifestation we have to keep in mind, such that when I see a woman or an adolescent with VHL, I always ask about her menstrual cycles. And if they're irregular, then I at least think about checking a testosterone, because most of these will secrete testosterone. Let's spend a few minutes on these, because I think these are the most confounding for endocrinologists, because this has not historically been something we deal with, but these are the hereditary paraganglioma syndromes. And there are 5 different ones, as you can see here. Basically, they were, described, this is the order they were described, and then eventually they found the gene that just happened to be these different subunits. So, because you might wonder, why does SDHA not PGL1? It would seem it would be 1, 2, 3, 4, A, B, C, D, but it's just the nature of how it was the timing of its description and the gene defect identified. But all of these are involved with the electron transport chain in the mitochondria. And so you can see there's these 4 SDH subunits that interact with SDHAF2. So any of these 5 can get mutations that lead to an increased risk of paraganglioma and pheochromocytoma development. And while I'm thinking about mutations. And just so you all remember, all of these are inactivating mutations in these are tumor suppressor genes. So all of these pretty much follow the rule like MEN1, where you inherit an abnormal gene from a parent, and then there's some other second somatic hit that knocks out the normal allele in the tissue, and that's what leads to the development of the tumor. So these are all autosomal dominant inactivating mutations. Okay, how many of you guys know Dave and Buster's? Yeah, we've all been there, right? Okay. So this is a little way I try to remember the difference in the two major familial paraganglioma syndromes. And the way I remember that is I think Dave Buster's, Dave and Buster's. And we can come up with a little bit of, using these letters to try to remember that. So Dave, I had a hard time with this one. I called it the dome of the body. It's head, and that's why I do this. Dave is head and neck. So SDHD mutations are associated primarily with head and neck tumors. Now, interestingly, this has a parent of origin effect. It used to be called imprinting. That term's not used anymore, but you only get a clinical manifestation if you inherit it from your father. So if you get an SDHD mutation from your mother, you are unlikely to ever have a tumor. But if you're a male and you have children, then your children are at risk for getting a tumor. So this is one of those that looks like it skips generations or has decreased penetrance. And then D is for dull. These are non-secretory, metastases are rare, so they don't really cause a lot of problems, but they can if they get very big. They can be quite difficult to treat. Now, on the other hand, the B side, the Busters, think of belly. These are going to be in your abdomen and pelvis. They're bad. There's a high rate of metastases with these, about 50% with SDHB mutations. And I'll call them boisterous. They're secretory. They bring a lot of life to the party in terms of hormonal secretion. So hopefully that's an easy way you can try to remember at least those two major ones. The others, particularly C and A, are so rare, I don't think we have yet quite a good understanding of those. Now, similar to VHL, paragangliomas are not the only tumor associated with an SDHX mutation, and that just means it's one of the subunits. So instead of saying ABCD, you just say SDHX, and it implies one of those subunits. So, and some of these fall into our category. So there is an association with pituitary tumors with an SDH mutation. We already mentioned that the paragangliomas, the pheochromocytomas, renal cell carcinoma can also occur. So kind of similar to VHL in that regard. And then this rare, tumor called a gastrointestinal stromal tumor. Now, again, the literature can be confusing. So there is this Carney-Stratakis dyad or syndrome, and that's basically a GIST plus a PPGL. But these are all pretty much SDH mutated patients. So I don't like eponyms so much. I think, the name should be driven by the gene. So I tend not to use this because basically it's just you have familial paraganglioma syndrome, and you just happen to have a GIST and a pheo or paraganglioma. And then, the NIH group also has called this 3PAs syndrome. That's basically paraganglioma plus pituitary adenoma. So just want you to be aware of those because it could be confusing when you read papers in the literature. Now, one thing that is still used eponymously is the Carney triad. And, Carney, if you guys don't know, is a very famous pathologist at the Mayo Clinic who first described, the Carney complex and, of course, Carney triad, and he's part of the Stratakis, the Carney-Stratakis dyad. But this is a very fascinating syndrome. I think I've only seen 3 or 4 patients with this, but it's a triad of paraganglioma, as you can see here in a patient who had, an AP window paraganglioma. So they have paraganglioma, but interestingly, they have these unusual lung lesions called pulmonary chondromas that show up as these calcified, masses in the chest. And then they also get gastrointestinal stromal tumor. This is a pretty significant one here. You can see, this tumor arising from the stomach. So that's called the Carney triad, not to be confused with the Carney complex. And also in the syndrome have been described adrenocortical tumors and leiomyomas of the esophagus. So these are almost always young women. It's not really hereditary. So this is not passed on from generation to generation. And what's been found so far molecularly is that there's a hypermethylation of the promoter of SDHC. So this is related to the SDHC, but not a mutation in the same vein as the paraganglioma syndromes, although about 10% have been reported to have these mutations. So in children, SDH, VHL are the two most common, hereditary syndromes that you will see. And it's interesting because they share a very common kind of molecular background, or they share a common background at the tissue level. As I mentioned, the SDH is involved in electron transport and energy production. And VHL is basically results in the tissues. Well, let me step back and just say both of these, the end result is that the tissue thinks it's not getting enough oxygen. So this is called a condition of pseudohypoxia. So the tissues think they're starving for oxygen, but they really aren't. It's just the nature of these mutations that lead to this. So it's that lack of oxygen, or that sense of lack of oxygen, that actually leads to the development of these tumors. So they have a very common background in terms of this. Okay, and we'll circle back to that again later. But let's talk about red mutations in MEN2, because again, that's people's first inclination to think of this as the most common syndrome. I won't belabor these because I think you guys know them well. But we have MEN2A, that's usually due to mutations in this extracellular part of the RET receptor. And pheochromocytomas occur in up to 50%, depending on the underlying mutation. So some RET mutations actually don't have a significantly heightened risk of pheochromocytoma. Now, MEN2B is the more severe clinical manifestation of a RET mutation. This is almost always caused by a single mutation in codon 918 that's actually located in the intracellular tyrosine kinase domain. So it basically constitutively activates this tyrosine kinase signaling, which is why it's worse. And pheochromocytoma occurs in about 50%. So of all the MEN2's patients, the MEN2Bs are the highest risk for getting a pheochromocytoma, followed by 634s, which is the classic MEN2A genotype. Let's briefly mention NF1. You guys know NF1 very well, but they are also at risk for getting pheochromocytomas primarily. But we don't routinely prospectively monitor them. But if you see an NF1 patient who has hypertension, then it's important to think, could this be related to a catecholamine secreting tumor? And partly, at least for us in pediatric side, it's because usually these pheos occur in older adults, 30, 40-year-olds. So we don't tend to see this diagnosis during childhood. MEN1 is another syndrome that has been associated with pheos, extraordinarily rare, but there have been cases. So same kind of concept. If you have hypertension, it's something to think about. But the difference with MEN1 is, remember, we're regularly screening their abdomens to look for pancreatic neuroendocrine tumors. So you would tend to see an adrenal mass, as it's developing. And of course, if you see that, we should also rule out pheochromocytoma. And these are the other genes that have been implicated in hereditary PPGL. And just to point out a couple of interesting points. So one is this MAX gene that we're learning more about, where pheo is part of it. But lately, there's been somewhat of a push to call this MEN5 because there's been families with this mutation who have been found to have other neuroendocrine tumors. So similar to MEN1. And I want to just point out, well, I think the next slide covers this, but we're learning more about PPGLs that arise in the context of cyanotic congenital heart disease, which is something that wasn't really an issue years ago because unfortunately these children didn't live long enough to necessarily get these manifestations. But now congenital heart patients are living into adulthood, and being followed. And it's been recognized that that is a risk for getting paragangliomas and pheochromocytomas, and I'll explain more in the next slide. And so there's now another syndrome that's been named for this kind of phenomenon. It's the Pachak-Zhuang syndrome, which is PPGL plus polycythemia. And interestingly, there's also patients who have somatostatinomas. And these are due to mutations in this gene here called EPAS1, which was also known as HIF2 alpha, which is all part of the VHL pathway. So you can see how they all kind of link together and kind of hypoxia flavors here. But interestingly, at least in this syndrome, it's not a germline mutation, it's postzygotic mutations, at least in cyanotic congenital heart disease. The ones that are germline are going to be more the congenital polycythemias. But it's kind of like McCune-Albright, that that's that postzygotic somatic mutation. So that's what's interesting about that particular syndrome. And then there's a smattering of others. These as well are associated with polycythemia. So what that would tell me is, like, we're seeing a patient with congenital cyanotic heart disease, okay, and they're hypertensive or having symptoms. Okay, bells might be ringing to screen them for PPGL. Or if you have a child with hypertension and unexplained polycythemia, that would be another reason to screen for these tumors. Now, the trouble with these is there's so few cases of these of kindreds with these mutations that it's still a little hard to describe these syndromes. We know there's incomplete penetrance, so not everyone gets it. These are typically adult onset. Few cases have been published, and because we don't have a lot of information, there's also not well-established screening guidelines. So if you happen to see someone with one of these rare, like a TMEM127, for example, it's like, wow, I don't know what to do. There's not really enough data to say when to start screening. So let's focus again on cyanotic congenital heart disease. This is a patient one of my colleagues recently saw, with a nice picture of had both a pheo and a paraganglioma, who had a long-standing history, she's in her 30s now, of cyanotic heart disease. And that's pretty much what's seen by the literature, is usually the median age of diagnosis is in the 4th decade of life, although you can see teenagers have been diagnosed with this condition. They present, as you would expect, with cardiovascular psychiatric symptoms. These also have a noradrenergic phenotype. I think these primarily are paragangliomas. So again, paragangliomas equals noradrenergic with few exceptions. And these patients have had cyanosis for many years. So in this case, it's not just that it's true hypoxia, right? It's not necessarily pseudo-hypoxia. So hopefully you can see the theme of, at least in children and some of these hereditary syndromes, that it's really driven by the actual oxygen levels or the tissue's sense of there not being normal oxygen levels that lends to these tumors. And EPAS mutations, the HIF2 alpha, those were found in 80% of those with congenital cyanotic heart disease. So I mentioned before that with the SDHD, right, the Dave part, that there's a parent of origin effect, and this is kind of what that looks like. This is a pedigree of one of our families, where you only get the disease, as you can see here, when you inherited from your father. But here you can see this woman had a lot of children, but none of them had clinical manifestations, yet they then had children who did. So we see that with SDHD, with this very rare gene here, and then also possibly MAX, although we're still learning a lot more about that gene. So VHL and the SDHs kind of cluster together. So they're officially considered, they're called cluster 1. So you can kind of separate these tumors into those driven by pseudohypoxia or those driven to abnormalities in tyrosine kinase signaling. So VHL and SDH are noradrenergic and they're in cluster 1. Whereas the other major syndromes we think about, the MEN2, NF1, sporadic tumors, they're adrenergic and they're in cluster 2. So they're working through a different signaling. The etiology is through tyrosine kinase signaling. As I mentioned earlier, it's all due to a difference in expression of this enzyme called PNMT. So one thing we'll be faced, in our clinics is you have a child who's known to have one of these hereditary predisposing syndromes, and like, what do we do, right? How do we screen for these tumors? So this is currently what the recommendations are. I think these are ever evolving. And the important thing to remember is most of these have been developed based on expert opinion and not really a really strict evaluation of the evidence in the literature. So you have to keep it a little bit in mind, that with a grain of salt, that these are not set in stone, but more a thought process. And the problem with this, and I can give a whole nother lecture on screening, but the problem is that historically screening for a hereditary tumor has been set at the youngest age that anyone has ever presented with that tumor. So if you have, so let's look at SDHB. So there's been a 5-year-old in the world who had a paraganglioma. So because of that, we should screen everyone below age 5. The reality is that very few kids are going to present at a young age, right? Most of them are going to present at an older age, but yet we set these screening thresholds at very young ages. And as the decades go on, guess what? There'll be a 4-year-old found someday with a tumor. There'll be a 3-year-old. So you just can't, keep going down. So I think we need to think more thoughtfully about how we make recommendations. So this is kind of what I do, but it doesn't mean it's the right or only way to do things. So the RET, there are, the American Thyroid Association guidelines do give some recommendations as to, when to start testing, which is between ages 11 and 16. I don't think anyone really follows this, to be honest. But of course, you always want to be aware of clinical signs and symptoms. And in this case, we actually do recommend annual metanephrine testing. For SDHB, and I only included this one because this is the most serious one. The others have gotten lumped into like just all SDH, but they're not all the same. SDH, for example, is a very typically benign tumor. And at 70 years of age, only 10% of people have had a manifestation. So you can't lump like SDHA with SDHB, very different disease process. So we focus on the most clinically relevant one. The typical age right now is 5, and that's based upon that case in the literature. And this is a little different than RET. So of course, you always want to look for signs and symptoms. In this case, we do more than metanephrines. So remember, so for RET, it's going to be an adrenergic tumor. You'll have elevated both norepi and epinephrine and their byproducts. Whereas SDHB is going to be more noradrenergic, but can also be dopaminergic. So the reason that we add the catecholamines is so you get the dopamine level. At least that's why I do it. And then chromogranin A, it's a little bit more controversial. I do it, but this is a marker that is secreted by endocrine tumors in general. So, an unexplained elevation of chromogranin A may lend itself to looking a little bit more closely that we're not missing, something that could be relevant for the patient. The problem with this and other SDHs is that not all of them make catecholamines. So for SDHB, you also do periodic imaging. And the imaging is for paragangliomas, but also for those other manifestations, renal cell carcinoma, GIST, and pituitary. So the imaging that, at least I do in very young children, I just start with abdominal pelvic ultrasounds and blood work and just clinical assessment. When the child gets older, I suggest whole body MRI. So we have, many institutions have this whole body MRI screening protocol that basically you're on the machine for about 45 minutes, an hour, and it basically just MRIs you from top to bottom. And that was developed primarily for Li-Fraumeni syndrome, where they can get brain tumors and sarcomas and all that. But we've adapted that for SDH as well. And most of the time, you're not going to find anything, but occasionally we'll see children, and I'll show you pictures of one, present with widespread metastases with clinically non-functioning tumors that you wish you just would have caught a little bit sooner. VHL, also age 5, very similar to SDHB, except we don't do the catecholamine and chromogranin A. And we don't do imaging specifically for pheochromocytoma here, but it's done for renal cell carcinoma and pancreatic neuroendocrine tumors. So you get a free look at the adrenal when you do those studies. One thing to remember, and one thing I've struggled with, is when you have a child that you're prospectively monitoring, it's like when you catch something early, it's kind of tough, right? It's like, what do I do with this? You know, the metanephrines are a little bit elevated. There might be an 8 mm little nodule developing in the adrenal gland. And so as one would expect, if you're prospectively monitoring these patients, you're going to find smaller tumors with less impressive metanephrine abnormalities. So you just have to keep that in mind. And the question is, well, what do you do with that? And I still don't know the answer, because some people will go for a long time without having any symptoms, and you don't necessarily want to send everyone to surgery just as the PHEO is developing if it's not causing them a problem. And again, a lot of that has to depend with malignancy risk. So if I'm finding a tumor developing in an SDHB patient, I'm going to be more likely to recommend surgery versus a VHL patient where malignant pheochromocytomas are rare. Okay, well, let's go through quickly this algorithm of, you have a child in your clinic and you're suspecting that they have a PHEO or paraganglioma. So the best test, only test you should start with is metanephrines. I do just plasma metanephrines because I think 24-hour urines are hard for a lot of people, but you could do a 24-hour urine metanephrine, but you don't have to do catecholamines. Metanephrines are so sensitive and specific that if you get a negative metanephrine in someone who's hypertensive and are having spells, that essentially rules out a pheochromocytoma. So you've seen this pathway before. Again, remembering we just want to do metanephrines. Now, if you're suspecting a dopaminergic tumor, you can measure this, but it's one of those things that you read about in the papers and, academic centers publish on, but you can't really easily order it. I'm only aware of the Mayo Clinic running a 24-hour urine for this test, so it's not so easy to get, but is the right answer if you're thinking a dopaminergic tumor and you want to look for that better. So you get your metanephrines back, and they're abnormal. So if they're normal, then you're done. You can always repeat it if the clinical suspicion is high. If they're really abnormal, then you probably got your diagnosis. Then you go straight to anatomic imaging. If they're kind of in between, then that's where you have to use your clinical judgment and either repeat them under more ideal conditions to make sure you don't have a false positive, or just watch the patient for a month or two and repeat them serially. So imaging, usually if I had my choice, I would go straight to a CT, a contrast enhanced CT that looks at the at the abdomen and pelvis. So you want to cover the adrenals all the way down through the pelvis. So on CT, PHEOs are these very vascular tumors. They look very classic in most cases. And they enhance very significantly after IV contrast. You can also do MRI. And on MRI, classically, they are bright on T2 weighted images. So that's kind of like one of the hallmarks of a pheochromocytoma or paraganglioma on MRI. They can also have cysts. They can also be hemorrhagic. They can be big. They can be small. So they have lots of different looks to them. So that would be the first thing. High metanephrines, high clinical suspicion, high pretest probability, go straight to CT, my preference, with contrast, or MRI if that's your institutional preference. So after that, then the question is, so say you see a mass, do you have to get functional imaging in everyone? So functional imaging is the MIBG scan or a dotatate PET. These are studies that kind of prove that this is a catecholamine secreting tumor. And no, you don't. But one thing I want you guys not to do is if you think there's a PHEO, to go straight to an MIBG scan. MIBG should be farther down. You really, you don't want to go hunting for a tumor with that. So let's talk about functional imaging. So there are several functional images or studies out there. So we've all heard about MIBG. You could also do octreotide scans, which really are no longer being used because those have been replaced by various PET agents that also bind to the somatostatin receptor. So FDG PET is a functional imaging. What we primarily use is what are called dotatate PETs that are either bound with gallium-68 or copper-64 is one of the newer ones out there. And then there's F-DOPA PETs as well that, Paul can teach me about because we don't have access to them. Those are not available at every institution, but, may have some value. Certain genetic syndromes may be more likely to be caught on a dopa PET versus a dotatate PET, for example. But I think in run-of-the-mill clinical practice, we get by with a dotatate PET and MIBG. And this, is just showing kind of the different receptors and how these work for the PPGL cell. So what do these look like? So here is an MIBG scan. And, most of the times, kind of like radioactive iodine, there's an I-123 version and an I-131 version. So the scanning one tends to be the I-123 MIBG. And you can see here it's quite positive in this patient with a pheochromocytoma. Here's a patient with MEN2 and bilateral pheos, where you can see here on SPECT CT, very, very nicely shows that. So I was mentioning I-123. So the therapeutic side of it is I-131 MIBG. So this is what an FDG PET looks like. You can see here paragangliomas and pheochromocytomas tend to be quite positive on PET. This is a patient with metastases, or no, these are primary tumors, I'm sorry. And this is what a PET CT, dotatate PET CT looks like. So I really find these to be beautiful studies, much better than MIBG scans if you're trying to look for evidence of metastases. So we're at the point now where we've gotten our functional imaging. When do I do functional imaging? Well, I do it in most kids, to be honest, because they're likely to have a hereditary syndrome. If they purely have VHL, I don't probably do it as much, because those are most likely to be pheochromocytomas, not paragangliomas. But stage B, I definitely do it to look for multifocal disease. And in someone presenting with a big tumor, we do it to look for metastases, because that might change your thought process of how you manage the patient. And they're so sensitive at picking up just tiny little bone metastases sometimes. So once you get through all that, then, again, you need to think about genetic testing and counseling. It used to be, we used to have to think and like, okay, what's the phenotype? What's the age of the patient? Is it noradrenergic, adrenergic? You remember the days where you just had Sanger sequencing and you had to pick one gene at a time to go through. So this was a paper we published, in 2010. And this is kind of how we thought about things. Like, this is the gene you'd start with. And then if that's negative, you go to gene number 2. But as you guys all know, this has all been now, it's all next generation sequencing. So it's easy now. You just one test, there's PPGL panels that include, these major genes. And just so you guys know, because I only learned this not so long ago, is when you order an NGS panel, say you send it to Invitae or Ambry or something, your genetic counselor, you write the genes you want tested. But because it's SNGS sequencing, they test all the genes. So you can always circle back and add genes later. There's a certain time period, but say, oh, we meant to check this. You can always circle back. It's just a matter of them disclosing those results. They don't have to run the test again. It's already there. It's just they don't disclose any results that you haven't ordered specifically. Okay, I don't want to spend a lot of time on this because it's, nothing much has changed with medical management, but in general, if you have like a kid with a pheochromocytoma who's hypertensive particularly, we tend to start first alpha blockers, and then we'll add beta blockers, particularly if they get tachycardic once starting the alpha blockade. And there's all these considerations. Again, these are so unusual. This has not been my experience of seeing a lot of these kids. Yes, some can be really sick, but usually the kids are okay. They're adults are more likely, for example, to get this Takotsubo cardiomyopathy due to high catecholamine excess. But basically, you start them on a medicine and you keep titrating up the medicine, to get their blood pressures at least normal for their height and age, ideally a little bit minimally orthostatic before surgery. And then preoperatively, we usually just do oral salt loading, where you just have them go crazy with the potato chips and the pickles and whatever else, and because you want to build up your intravascular volume, and that's why you do that. And then, of course, you need to have a good team set up to remove these tumors. And it's interesting, I just recently saw a presentation in adults where, people are questioning now, do you really need to prepare these patients so stringently for pheochromocytoma resection? Because in the end of the day, it's really about the anesthesia team. And so, I'm blessed where we are. We have anesthesiologists who don't bat an eye at removing huge Goomba tumors. And so they're there with their antihypertensive drip. And then when the tumor's out, they're there with their, epi drip or norepi drip. And so really, if the anesthesiologist is comfortable managing this, the pre-op stuff doesn't make as much difference, but you still want to make sure they're adequately blocked. But I think the reality in today's world, it's not like 30, 40 years ago where you'd see these case reports of people dying on, I think we're more advanced now. But anyway, officially, you're supposed to use alpha and beta blockade. Some people even arguing you can just use calcium channel blockers and don't have to do alpha and beta blockers. So that's kind of evolving a little bit, primarily on the adult side. So surgery, for PHEOs, if they're really big, then there's more of a concern. It could be a malignant tumor. So we usually consider PHEOs over 5 centimeters to be on the bigger side. So we would tend to favor open surgeries. But for most of our situation, which will be VHL patients with pheochromocytoma, we now do this posterior retroperitoneal laparoscopy. You see the patient is kind of, laid down over the table in a position, I hope, a little vulnerable there. But that's how they insufflate the retroperitoneum. And, they remove it through the back, and the recovery is incredibly fast. Patients usually just stay one night in the hospital after this type of procedure. So this has become the treatment of choice for patients with hereditary, most patients actually, not just hereditary, with small pheochromocytomas. In all of the hereditary cases, we also have to add another level. So there's a surgical approach, but also how much of the adrenal do you remove? Because these patients are at risk for getting PHEOs on both sides, and you don't necessarily want to burn bridges if they're going to get a PHEO on the contralateral side. So we always first try a cortical sparing approach. If it's feasible, we just remove, the tumor, but leave normal cortex behind so that still functions normally. So then if they get a PHEO on the other side that you can't do cortical sparing, you have to remove the whole side, you still can depend on what's left. Now, of course, there's a higher recurrence rate if you do a cortical sparing, but I think the trade-off is that you don't have to be dependent on steroids the rest of your lives. And so I think most people are willing to accept that. And this is, again, for the pheochromocytomas that don't have malignant potential, right? If we're concerned about cancer, we want the whole thing gone. So this is more for VHL and MEN2. One thing to remember is that lifelong follow-up is required. You've seen this picture before, but this is a patient who had a paraganglioma at age 15. I met her at age 31 when she had refractory hypertension when she was pregnant. And long story short, she had a metastatic lymph node. I'm still surprised she was so hypertensive with this. But, you can see 16 years later, we diagnosed her with metastatic paraganglioma. So if you follow these patients as children, please make sure they switch to an adult practice that can keep monitoring for these tumors. So let's wrap up with metastatic. I know you guys won't be dealing with this, but I just wanted to bring you up to date with kind of where we're at with this disease. All adrenal tumors, really, there's no histologic guarantee that it's benign or malignant. So it's the same with cortical tumors or pheochromocytomas or even paragangliomas. All you can say is, well, it might have high mitoses, the Ki67 is high, but the only way you know it's malignant is if it spreads somewhere it shouldn't be, if you find it in a lymph node, liver, bones, or elsewhere. So getting a benign report from resection does not reassure you that it's not a malignant tumor, okay? So just keep that in mind. The malignancy rate is much higher for paragangliomas, much higher for sympathetic tumors. I already mentioned the 5 centimeter threshold. And then SDHB positive. So these are the highest risk factors for having malignant disease. And you can see here, this is an unfortunate, this was a metastatic PHEO in a teenager. I'd never seen such a case like this. When he unfortunately died of his disease, he had no germline mutations. So I'm not quite sure what's going on in his case. So when we identify a malignant or metastatic PHEO, we have different options. Historically, we have this cytotoxic triplet called CVD that is used. It's fairly well tolerated, and you can see a response in about a third of patients. So we tend to reserve this now for people with rapidly progressing disease, where they would benefit from cytotoxics. Now there's this whole new field of theranostics. So a theranostic is an agent that you use for both imaging and treatment. Okay. So MIBG is a theranostic, and dotatate is a theranostic as well. So here's, for example, gallium dotatate that you use for diagnosis, but there's also this same molecule just bound to either yttrium or lutetium. This now emits the beta particles that emit, irradiation for tissue killing. So the same kind of molecule attaching to the somatostatin receptor 2 can both help in diagnosis and in treatment. And when we use agents like this, it's also known as peptide receptor radionuclide therapy. You guys may have heard that PRRT is the term used for that. But MIBG is also a theranostic, right? You can use I-120 or 123 iodine, MIBG for diagnosis. But the only FDA-approved drug that's out there to treat metastatic PHEO is this drug. The brand name is Azedra. It's I-131 MIBG. And it's actually approved for 12 years and older. So we actually have a pediatric indication as well. So again, showing you the situations you might consider it. This is actually the same patient, a teenager with widespread metastases. This is what the dotatate PET looked like. This is his iobenguan I-131 scan. This is the actual agent that is administered. So you can see how, there's good uptake on both of these scans, and that's why you can target these with these radiopharmaceuticals. This was his response. We treated him with 2 courses of high-specific activity MIBG, and you can see he did have a nice clinical response with, decrease in the mets. These are actually dotatate PETs, not MIBGs. And then there's lots of other molecules that we're using in endocrine tumors, all the IBs, as well as there's some evidence that, maybe immunotherapy may be helpful in certain situations. So I just want you to know that there's a lot of different compounds that are being studied for the treatment of this disease. And of course, whenever we're dealing with a rare tumor and we want to figure out what we can do, it's best to look at clinicaltrials.gov, see what open studies they might be able to enroll in. And then finally, I want to end with this drug called belzutifan. This is a new kid on the block. So this is a drug that actually targets HIF-2 alpha, which you remember is the main component of von Hippel-Lindau disease. So when you have VHL disease, your HIF-2 alpha goes up at the tissue level because your tissue thinks it's not getting enough oxygen. So this is a HIF-2 alpha inhibitor. It is FDA approved for the treatment of VHL-related tumors. Primarily, this was through renal cell carcinoma. But there is a clinical trial using this drug for metastatic paraganglioma and pheochromocytoma. And we have seen some good responses, including in SDHB patients. Again, given they share that same kind of hypoxic, pseudohypoxic pathway. So this you may be hearing more about this drug moving forward. So in summary, hopefully we've all learned that, these are rare tumors, but they can occur in up to 2% of the hypertensive pediatric population. They're more likely to be what we call cluster 1, VHL, SDH, that makes norepi and normetanephrine only. And they tend to be more multifocal and bilateral. Common syndromes, the malignancy risk is high, particularly for SDHB. So that's the one we have to give the most respect to. And lifelong follow-up is necessary, both for delayed diagnosis of metastasis, as well as other primary tumors that can arise in that patient's care. And then currently, we do have screening recommendations if you have an asymptomatic child with a genetic mutation that incorporates labs and imagings. But remember that this is not very evidence-based recommendations and mostly just based on expert opinion. And I left you with the knowledge that there are novel therapies being developed and studied for the treatment of these tumors. Okay, I know it's been a full hour, but thank you so much for your attention. I appreciate it.
Thank you for a great talk. Do we have any questions in the audience?
I bored you to death. You're like, I don't know. I'm brain dead.
I wanted to ask a question, actually. So we spoke about screening when we know about the genetic mutation, but when do you recommend to screen for PHEO or PPGL, a child that comes with hypertension without no family history of tumors? Like, do you recommend to do it routinely, or it's more like when we have other suspicion?
Yeah, it's hard to say because you're going to screen for finding up to 2%, right? So you're going to tend to overscreen a lot. So I guess it's more of those cases where it just doesn't quite fit. The child's not obese. There's no family history of hypertension. So I think any child you think might have secondary hypertension, I would do it. But if you see an obese 17-year-old you're treating for type 2 diabetes who's a little hypertensive, then yeah, I think I wouldn't in that case.
Thank you.
Yeah, I think there was a question there. Yeah.
I had a question about those cases associated with cyanotic congenital heart disease. The persistence of the mass growth even after correction of the cyanotic lesion, does that speak to the presence of like local factors, cytokines that are still expressed genetically despite the, hey, I've replaced a heart valve, I've closed this off, we are no longer experiencing hypoxia?
That's a great question. My understanding is that a lot of those may be somatic mutations. So I guess if you've already had that mutation developed that gave rise to the tumor, then no matter what the environment is now, it's going to just do its thing. But admittedly, I have a very weak knowledge in that particular area.
Steve, thanks for that presentation. Is there any research on preventing tumors in genetically predisposed subjects?
Not that I'm aware of.
Slightly related, but maybe unrelated. I had a question that recently came up, a patient that had POTS. Usually when they do the tilt test, the epi and the norepi goes up. And if it goes up a little higher, they ask me, should I be testing for some of these things? And do you have any comment on that? Or?
Yeah, so I think, in that case, I'd probably argue for repeating it under ideal situations. I didn't realize they actually will check it during the tilt table test. Oh, okay. Yeah, I'm not as, okay. All right. Yeah, because POTS, I understand it's dysautonomia, right? It's autonomic dysfunction. So I don't, I guess, get too excited if they're at least, if it's over 4 times upper limit of normal, that's clearly abnormal, right? If it's less than 2, I'm probably okay, not worrying about it. If it's between 2 and 4, then I'd be like, maybe worth repeating it under the ideal situation. I usually just draw the metanephrines, but ideally you're supposed to have supine rest for 30 minutes. If you really want to go crazy, you place an IV, then have them rest, and then draw it from the IV. But usually I just draw it randomly, because if it's negative, then you got your answer. But if it's positive, then you have to repeat it. But I guess that's how I would think about that situation. Those are tough. Those POTS cases are tough because, yeah.
We're kind of running out of time.
Yes.
If there are any questions in the chat.
Nope, just a comment from Michelle. Hi, Michelle. Thanks.
I think there was one more question.
This is a little bit of a workup type question. You may recall I had curbsided you maybe a year or 2 ago about a patient with MEN2B. So, genetics proven, family history. And the patient sort of got lost to follow-up, but came back and saw one of the nurse practitioners and was normotensive, but his plasma metanephrines were elevated. So he is on ADHD medication, probably had been taken off enough, but because he's not symptomatic, and just to be sure before I start to head down the road, I'm going to redo making sure that he's, supine, making sure that all those things are done. But let's say that they do again come back abnormal. Is it, from your talk, would you do both imaging either with a CT or MR and do functional imaging as well with like MIBG or dotatate on him?
Yeah, if I had a strong clinical suspicion, then I guess it's not unreasonable to just image the abdomen and pelvis, because almost all the tumors are going to be there. And if that comes back negative, then I wouldn't necessarily pursue functional imaging.
The reason I was thinking about that is, would I want to get functional imaging if there is a suspicious lesion to look for metastases, just to guide, surgical management?
Oh, you mean if you found the lesion?
Right. Let's say that, this does prove to be a lesion that looks suspicious after, the biochemical testing comes back concerning also.
Yeah, I guess one, it depends on, I guess, how big it is. And, if you have time to get genetic testing, although usually we don't do it until you actually know the
He already
diagnosis.
had genetic
I'm
testing.
sorry, he has MEN2.
Right, he has 2B. So he has
Oh, 2B.
a
Oh,
bad one.
I'm sorry. So 2Bs are a little different. So in MEN2, particularly 2Bs, they can get adrenal medullary hyperplasia. So if you actually resect an adrenal out of them and look at it, they have big medullas. So they can have minimally elevated metanephrines just due to hyperplasia. So if I saw a discrete nodule, then I would believe it more. And in that case, I don't do functional imaging because they have MEN2B. We've seen only 2 or 3 cases of metastases in that situation. So they're going to be intraadrenal. And I think you have enough information.
Okay, thank you.
Yeah.